Finally, treatment follow-through. So I'm a big believer in monitoring kids through at least their school years, and I think increasingly so should be monitored into at least early adult years. I think it's always important to be aware of the fact that things are going to show up at different times, and you need to be anticipating proactively about them. I think it's also clear that these are complicated kids and that it takes time. It takes a long time sometimes to really stabilize these kids. So I will generally say to parents, if I'm treating a child who has one psychiatric diagnosis that I'm going to be treating, it's going to take me 1 year. It's going to take me 2 years to treat 2 and 3 to treat 3. Now, it doesn't take me that long. But the idea is you need to really let things settle and for things to readjust themselves and for the system to kind of adapt to the new changes before you can move on to something else. So it does take time. And you have to be aware of the fact, especially with these complex neuropsychiatric kids, that multiple medications are often part of the picture. At the 2-year visit with the psychiatrist, DJ's now 13, things are not going well. The family's worried about his transition to high school. His marks are slipping again. The school did do a psychoed, and they have now identified that he does have a reading disability, and he's doing some tutoring in regards to that. But again, he's falling behind, mostly because of incompletes, not handing things in. He's also become more reclusive again. Now, when you take his weight, you find out that DJ's actually doubled in his weight since he first got started on his stimulant medication. He's also older. You expect to be putting on some weight. He's not obese. But his methylphenidate dose has not changed. And I bring this up because I want to bring your attention to the fact that methylphenidate, Ritalin, dextrin are the only medications in psychiatry that are really dose-based, or weight-based, I should say. So that as a child's weight increases, you need to keep on top of it by increasing the dose of the stimulant medication. Almost every other medication in child psychiatry that we use is not weight-based or age-based, which is really cool, because if you find the appropriate dose for an SSRI for a kid, it's likely to be the same SSRI dose in perpetuity. Why? Because younger kids, even though they're smaller, have very, very active livers, and they burn it up much more quickly. When as you get older, your livers slow down, and it distributes, but your blood levels stay about the same. But with ADHD, again, one of the most common things I hear about is, yeah, he was diagnosed with ADHD, he got started on treatment a few years ago, but look, it's still happening. But no one's actually made the change in terms of monitoring his dose and changing the dose and adjusting it for him. So you also learn that he's starting to get quite fixated again, and this time is on his earthquake interest has turned into plate tectonics. He's a smart little boy. And he's spending lots and lots of time trying to figure out when the next big quake is going to be. And in fact, maybe up to 3 hours a day just researching and getting information on earthquakes. And this is, I would call, a pretty intrusive compulsion. So the doctor diagnoses obsessive compulsive disorder at this point and increases the dose of his SSRI over the next 6 months. And this lessens the amount of time that DJ spends on his fixations. It doesn't really help a lot with school. Now, the point of this part of it is to understand that SSRIs need also to be adjusted, that when you're treating anxiety disorders, although they're a continuum, OCD is on one end of the continuum that often requires a much higher dose. And that generalized anxiety, social anxiety often respond to a lower dose. And so it is sometimes happened that if you see this evolution, you've treated a kid for social anxiety, you've got him on a reasonable dose of an SSRI, and OCD shows up, it may be that you need to go to the next level in order to treat the OCD. The other thing is that is the issue in terms of his school. And grade 9 is very challenging, so he puts, the psychiatrist increases his dose to an appropriate range, and by grade 10, he is back in the groove. When DJ is 17, the family requests another review by the psychiatrist. DJ is still taking his medication, the SSRI and the stimulants, which now has been periodically adjusted to keep up with his growth. He doesn't think the medication is doing anything anymore. When he asks his mom, he says, she's been on it so long, I don't know anymore either. And he's kind of like, I don't really want to be on the medication. I really have to take the medication. The mom not really sure either, but she doesn't want anything to change and make things too hard. There's a big transition coming up. And bigger is that he's transitioning out of his services, that he is getting to that point where he's going to outgrow child and adolescent services, child psychiatry, pediatrics, and no one knows what's going to follow. And we don't. And so the next, I think, landscape for us to be looking at is these kids past age 20. So what happens? And I don't think we know. We know a little bit, and we're learning more and more every year, but I think it's going to be very interesting. My initial sense is that I think we are looking at more evolution and more development in kids well into their 20s.